You know that. Thank you, Allison. Appreciate the introduction. It's also nice to meet you in person, and again, just wanted to thank you for everything you've done with the Ebola, because you really have helped us out. I mean, Allison is known as Allison Ebola down at the State Division of Public Health. You know, I couldn't even remember what her last name was until she just said it. So, but well, I was just going to make a comment on the types of campaigns of vaccine. We're starting a kind of really neat one down in Madison, where we have actually partnered with the UW football team, and during the timeouts at the football games and at halftime, they have Matt LePay, who's the play-by-play person, talking about getting your flu shot, how important it is, and then sponsored by the Division of Public Health and Department of Health and Social Services. So really excited about that. I think it's going to be advertised starting this weekend when Wisconsin plays Troy. No idea where Troy is. But it's going to be a wipeout. So, you know, but I think a lot of people will go just to hear that influenza PSA. At least that's my personal opinion for what it's worth. So I was going to just start off and tell you a little bit about what happened last year, and then get into our different surveillance programs and methods. Allison and I were just talking before when we got here, you know, how's it looking this year compared to last year? But last year by this time, we were shaking in our boots, because we knew at that point that the influenza AH3 was not going to match. We actually had a pretty good idea that back in April when they started to come in. They were coming in as A Switzerland. They should have been the A California, not A California, I can't remember what the other one was. But, you know, it was to the point where we were hoping, even up until this point in September, that we were going to have H1 year and that we're going to have a better match. It didn't turn out to be that way. And as a result, I can't say it's a surprise, but we had probably our worst year on record, including the influenza pandemic back in 2009. I mean, we shattered records, you know, bad records, you know, for most number of hospitalizations. It was probably in the area of 4,700 last year, whereas we only had only 2,900 back in the influenza pandemic. We knew what was going on. This result had major side effects. The nursing homes were hit very, very hard last year. We had well over 350 outbreaks in long-term care, and that's the continuum of care. Talking CBRFs, nursing homes, we're talking RCACs, which is resident care, apartment complexes. We had so many where we couldn't even keep track anymore. So that's why I say over 350, it could be a lot more. Our system didn't work as good, and that's my issue to deal with, not yours. But again, as a result of all of those particular outbreaks and the mismatch, which meant that the Tamiflu had to be given to not only all residents, which we do every year, but also to all staff because the match was not there. We ran into delays, major delays in the delivery of Tamiflu, where we at the Division of Public Health had to go into our influenza cache, our antiviral cache, which was meant for pandemics. So we had people on December 31st going all over the state. Many thanks to Don Neward and to Joe Cordova, and some of those people, you might mention their names, might know their names, but they were traveling all over the state trying to get the Tamiflu boxes to the affected long-term care facilities so they could get the people on Tamiflu ASAP. Otherwise, it would have been 2 weeks later, and we would have had even more fatalities than what we did. I know of at least a couple facilities that had half a dozen to 8 fatalities due to influenza last year. They were giving me originally, the reports from our vital records office on a daily basis. It's got to the point where, first of all, I didn't realize they were costing us $25 a piece. Oops. That's going to come up in next year's budget. But, you know, I just said, that's enough. We need to just stop doing this. We need to follow up and really get going. And, you know, I put together some protocols so people know what to do, when to do, and how to do it. So far this year, all of the characteristics of the viruses have come back, and they've been in the vaccine. It's been A Switzerland. No surprises yet. The B's have been the B, careful with the pronunciation, Phuket. If it's not Phuket, I don't care. You pronounce it any way you want. You know, Phuket. You know, which is in the Yamagata strain and the trivalent. We haven't had any Brisbane that have come back yet. That's the Victoria strain. That's in the quadrivalent vaccine. Anybody got their vaccinations yet? 2. All right. Thank you. I was hoping it was going to be 3 and I could raise my hand, but my facility does not yet have a quadrivalent vaccine. So, and I will get nothing but the quadrivalent vaccine. So help me God. That's just the way it's going to be. So that's kind of an overview of what happened last year. As I said, it was not a surprise to us. Very unfortunate. I don't know what more we could have really done other than what we already had done. I think we did a heck of a job trying to get, make the policies put together to get the antivirals out due to the antiviral, again, I'll call it a delay versus a shortage. But will that happen again this year? I hope not. I hope everybody has the policies. We're going to be posting them on our website, our PCA portal. This is how you get antivirals if you need them. Okay, so it's not going to be, hey, I just want to stock up in case. That's not going to be it. You have to tell me that you need them for an outbreak, for something that's going on, and that you've exhausted your efforts to get the antivirals through your normal sources. So that's going to be our rules with that. So on that, let's just talk a little bit about our surveillance systems. Am I coming through, Matt? Good. If I get too far over, just get over. Okay, we really have 3 surveillance systems. Well, we have many surveillance systems, but our main 3 are influenza-like illness, outpatient surveillance, which influenza illness is defined for surveillance purposes. As fever over 100 degrees with cough or sore throat. That's it. Very simple, very to the point. That's something that's been going on since 1997. It was the main method of our influenza surveillance during the influenza pandemic, and it really helped a lot. It really showed the peaks, the multiple peaks that we had during the influenza pandemic. It worked out very, very well. It also showed the peaks, the original peak in fall, in spring, that was in the southeastern area, specifically Milwaukee, and how that went down in the second peak in spring. So our influenza-like illness project has been going on since 1997. It's really one of the main cogs. We are also at the Division of Public Health blessed to have one of the best state labs, in my opinion, in the country. And we've tried to take advantage of them. Well, maybe that's not the right thing to say. Tried to take advantage of our partnership is what we wanted to do, really. We talk to them on a periodic basis. We make decisions together. We meet with the bacterial people. They meet on a weekly basis. I meet with the viral people on a monthly basis. We actually have a meeting that we affectionately call Flu and Poop, because we have several influenza surveillance projects, and also a diarrheal component. And Dr. John Tempe, who is one of the main, actually was the head of ACIP for the country for the last 4 years, up until this past few months. He kind of just was talking off the cuff one day, and he says, this has got to be a flu and flu meeting, right? It's like, we actually have, that's become known by nationwide, that we have had these particular meetings. And we meet monthly at a coffee shop in Oregon, Wisconsin, because 5 out of the 6 people who meet there are from a 5-mile radius. So it's a nice place to just sit and meet and talk amongst, without having any kind of bureaucrats around us, everybody listening. We just sit back, try to get a back room, because it's not always very conducive to having a table right in the middle of the room, because other people like their coffee. So, but we have been blessed to have that. And our laboratory surveillance, which again is basically number of tests and number of positives. It's not only for influenza, we do it for RSV, we do it for human metapneumovirus, we do it for adenovirus, we do it for about 14 different things. So that's number 2. The third one is our influenza hospitalizations. As I mentioned, we had over 4,700 this past year, breaking the records by almost 100%. And again, definition of that is very simple. Hospitalization with confirmed flu, and that would be either through a rapid test or a PCR. Not many cultures done these days, not many DFAs at all. I don't think I've had a DFA for a couple of years. But again, that's our source of severity. It's really worked out very, very well. And again, this past year we had 4,700 more, 70% were over 65 years old. Usually they average between 55 and 60%. But this year it was massive. The previous year before that, that was between 2013-14, when we had the H1 year, that hit the younger and middle-aged adults, much higher than it did the elderly population. So it's definitely, these influenza viruses are age-specific as to who they're going to hit. But what I did is I put together some information. Looking at the first chart on the first page, that's a chart of percent influenza-like illness versus laboratory positive, and that's for the state of Wisconsin. And you can kind of see that everything peaked right around Christmas time, between Christmas and New Year's. And I'm showing this because I really want to show the correlation of these particular influenza surveillance systems. It has been in the last few years an early year, usually we average late January, early February. If you go back about 4 or 5 years, we had several years where we didn't peak until March or even April. So the last 2 years have been very early, right around Christmas time, just an FYI, at Christmas time and New Year's time and Thanksgiving are probably the 3 weeks out of the year where we don't get the greatest number of data because a lot of places are closed. But it really does show a very good correlation on this, that we did indeed peak. But about 6 years ago, what we did is we realized that people up in Eau Claire in this area really don't care what's happening in Milwaukee. You know, and no offense, but they don't care what's happening to you guys either. So, you know, so we decided we have to start breaking this up. I mean, we can't do it by community, so we do it by region. We try to get it as close as possible to a particular area. And the second chart is percent influenza-like illness and the percent lab positive for flu in our western Wisconsin regions. And again, it's very close correlation, about 1 week off, showing the peak of influenza activity right around the last week of December. So again, it was very close to what's been happening throughout the state. It is a little bit different in Milwaukee area. They peaked a little bit earlier, but again, it's not uncommon to have those types of differences. You know, because one is closer to Chicago, which might have a bigger peak going on. Yeah, up here you have it closer to Minneapolis, St. Paul. So it's not uncommon that, so some people say, oh my God, we're peaking a week earlier, our system's wrong. It's like, no, it's not. It can be just very diverse, even throughout the states. And that's why we put this into regions, because we really wanted people to know what's going on as close as possible to their particular areas. We were hoping next year, we have a lot of this influenza, like laboratory reports, is based on rapid influenza tests. But we're hoping we can break it down by PCR, which is even more accurate than the rapid influenza tests. That's still something in the works. Will it work this year? I'm cautiously optimistic, but also this year, just so you know too, we're also going to be breaking down our data to break down the influenza Bs. And that's really important for those people who have only the trivalent vaccine, to make sure that they are covered in case we have some kind of an outbreak of the Victoria strain, which is not covered in the influenza trivalent vaccine, but is covered in the quadrivalent. Nursing home people, just so you know, we keep, one more sentence. You know, nursing home people, what did I gotta say? Nursing home people, hey. We keep pushing, you know, to at least consider the fact that the high-dose flu zone, the only problem with the high-dose flu zone is that it is a trivalent vaccine. So, did you have a question that I can answer?
Well, not a question. We only purchased the quadrivalent. I do the purchasing for pharmacy, and we only purchased the quadrivalent this year. So
good for you.
Just wanted to throw that out there.
Yeah, and we're getting it at our one was supposed in our state office building next week, and they actually got the quadrivalent as well. So, you know, but I think it's very important, because last year it was about 70-30 with the Victoria versus the Yamagata, which is in the both of them, and the Victoria, which is strictly into the trivalent vaccine. So we had had outbreaks of influenza B last year. By the time we found out what it was too late. So, okay. So again, the consistency of influenza-like illness and the percent positive for flu. This, by the way, you'll find in your weekly reports. Hopefully people see my weekly reports or know how to get hold of my weekly reports, or don't you know what I'm talking about when I say weekly reports? Anybody not know what I'm talking about? Feel free. Don't know what I'm talking about? You do? Okay. Yeah, it's on our website. It's on our DHS website. It's also on flu.wisconsin.gov. We also send it out to about 800 people who have problems. We've had a lot of problems in the past with our website that person doesn't have influenza, I can tell by the cough. And I've experience in that. But again, we've had some problems where it's been hidden in our website. We were trying to make it better, so it's maybe a 1 or 2 button push to get to it. I think it's better. I don't think it's as good as what I would like to see. I know some people don't have the patience to go through step 1, step 2, and step 3. So I would like to try to make it where something's on our front of our website where they can push a button and get the weekly report and know what's going on in their facility. Now let's take a look at the next page, and that's the influenza-like illness compared to hospitalizations. And again, the top one is Wisconsin. Notice, if you would, the line is the number of, I forgot to change the legend on this. I'm sorry about that. So, you know, it's not the number positive. It should be hospitalizations. That's the bar. That's the bar. But we actually, in the weeks of December 13th, 20th, and 27th, we had over 800 hospitalizations a week. You know, compare that to like the 2010, 2011 year. The whole year we got 350. But it was overwhelming to really follow up on these particular things. And Again, hospitals are starting to lose space. There were some diversions going on. It was, without a doubt, one of the most difficult years that we've ever been around. But again, you can kind of see the correlation in late December between the number of hospitalizations and the ILI percentage. So my whole point of these things is to really tell you that all of these particular programs really fit together well. We've been working on them for years. We really feel that the laboratory, the ILI, and the hospitalizations are three main methods to really follow up on. We have not had any instances where it's been totally diverse, where one is saying yes and the other is saying no. These are real consistent programs, and that increases the cooperation that we have with the state laboratory hygiene, with the hospitals. The infection control people have been great, you know, as far as reporting this. Thank you very much. Appreciate it very much. But if it becomes overwhelming, call me. Don't know that I can do anything, but call me. We'll go from there. But I just want to show you the numbers that we had for this past year. Now, the question has come up, when does the year start and when does the year end? I don't know. That's hard to say. For surveillance purposes, I'm starting over October 1st. But we've actually had one influenza outbreak in a nursing home. I'm counting that in the 2014-15 year. That happened last week. Am I doing it right? Am I doing it wrong? I don't know. It's not really happened before, so if I have to change my ways, I'll change my ways. But you can see 4,716 hospitalizations, of which 3,310 were over 65 years old. Massive number of outbreaks this past year, records. And this is not only in the state of Wisconsin, this is throughout the Midwest and also the United States. We put together a program of surveillance with the other Midwest states about 6 years ago, where we meet on a monthly basis and we talk. It's just our influenza coordinators. So, and we talk very casually amongst each other. We don't have any management there. We don't have any CDC. It's like, what are you seeing? What's going on? Are you seeing increased hospitalizations? Are you seeing it in a particular age group? Are you seeing people put on ECMO more often, which is what we had several years ago? A lot of patients were actually being put onto ECMO compared to what we had normally had seen. So it's just a way of communications to find out what's going on in our area. It's very casual. It's something that we all kind of look forward to. I kind of changed the name of it this year. I called it the Midwest Coordinators of the MC Packers, so we're the McPackers. The other 10 states didn't like it, but they didn't come up with anything better either, so. Yeah. But I thought that would be kind of interesting to do. But it's something that a lot of regions of the state are going to be copying us. And again, to me, you can have your 50-state calls, but I don't get a lot out of those because there's so many people on. But when you have 10 people on just to talk and we're friends, we've known each other for years, it really has been a godsend. Oops. Thank you. I wanted to make sure that was caught on camera. Okay, Allison also wanted me to talk a little bit about antiviral agents, specifically Tamiflu. And you know, we're running a state out. For every Tamiflu you get 2 lenses with it, because we can't get rid of this stuff at the state. Nobody wants it. It's just sitting there. It's going to probably sit there till it's expired. But the antiviral practices per the Advisory Committee on Immunization really have not changed since January 21st of 2011. And that's again dealing with outbreaks, especially in long-term care. The chemoprophylaxis should be administered to all eligible residents regardless of whether they received vaccination during the previous year, and should continue for up to 2 weeks. These are the same recommendations that we send out every year in our influenza long-term care memo. We're not making anything up here. If surveillance indicates that new cases continue to occur, chemoprophylaxis should continue until approximately 10 days after the last onset of illness. We say 7 to 10 days, 7 to 10 days. So it's not like you put it on for 2 weeks, you continue to have cases, you can automatically stop. These things can actually blow up into long-term care facilities big time. We had cases last year, 50, 60, 70 residents come down with it. And again, multiple fatalities. The last portion on there is probably the most interesting and the one that people didn't realize. It's that chemoprophylaxis for all employees, regardless of influenza vaccination, if indications indicate that the outbreak is caused by a strain that is not well matched by the vaccine. As soon as we figured it out last year that they were influenza A, H3s, we had very few H1s last year, by the way. And approximately 70% of the influenza H3s were the drift strain. And the only ones that weren't were at the beginning of the season. So as we got into January, we were pretty sure, almost 100% sure, that these are the drifted strains. So we made that recommendation that if you have an affected unit or a building, some places are really small, it affects the whole building. If it can be contained, you can do it to one unit. That is not only the residents, regardless of vaccination, but also the staff that need to be put on prophylaxis. And that's what led to the delay into the delay of the delivery of antivirals, which is why we had to get into our state cash. Now, I know there's been some talk, I think especially up in this area, about the efficacy of Tamiflu. The article that I'm listening here, that's available, Clinical Infectious Disease, just came out this week. And it really talks about the efficacy of amongst people over 65 years old to reduce the severity of the illness. And there's never really been any doubt that if you put people on early enough that it is an effective prophylactic. Now, is it the same for pediatrics? There's pediatrics, yes, there's possibility of some side effects, but we really haven't heard about that anywhere, of anything that's very severe. Now, if you have stories to tell me, please tell me, and let's share our stories with that. But I've not heard of anything other than in Japan, they had instances where they were on kids on Tamiflu where it led to convulsions and CNS type of problems. Have any of you run across any problems in the pediatric population putting people on Tamiflu? Anybody at all? If you do, call me, or Allison knows how to get a hold of me, or Paula. I'll let any of those people know how to get a hold of me. But I'd be very interested to know about that. Because that's, again, I've heard, again, from people in this area that there's a lot of clinicians are really poo-pooing the idea of putting on Tamiflu because they simply don't think it's effective. I do. I think it's very effective in reducing the severity, reducing the shedding period, and obviously I think it's very good for prophylaxis. Last year, again, this is all we had going for us in nursing homes to try to keep people alive. And I think we did a pretty good job. Probably could have done a little bit better, but then again, I'm not going to second guess myself. There's things that I'm thinking about this year about how we can get it out quicker, getting that message out. It's just, it's going to be hopefully not nearly a severe year this coming year, but we just don't know until we get into it. But take a look at this article. It's very, very interesting. I was going to make copies of it, and I thought, well, I had enough trouble just making paper. Pharmacy lady, yes?
I'm sorry. Do you recommend...
Do you mind if I call you pharmacy lady?
Sure.
Since I don't know who you are, I'm sorry. Oh.
My name is Emily, but do you recommend purchasing as much Tamiflu as we did last year? I mean, it was a huge dent in our budget. I'm just curious if you still recommend purchasing that much.
I would. Based on last year, I think we're a little paranoid too. Again, we're there to help supplement if you do run out, especially if it's an outbreak situation. But I think I would continue on with it, and maybe it's just because of what happened last year, maybe it's paranoia on my part. But that my personal feeling is, yes, I would do as much. Do you do any Influenza at all? No?
I don't want any either.
We got to have a 2-for-1, 3-for-1 sale, something. Joe Cordova is the one who handles all this stuff, and he's just begging for people to take Influenza, and nobody will take it. Not even staff.
I don't even know that it's on our formulary anymore.
Oh, really?
I'm not sure.
Yeah, well, the whole purpose why we got Relenza back in 2007 when we purchased this was the idea if we had a pandemic, making sure that one of the two was going to be susceptible in case there was a resistance pattern. We were fortunate during 2009 that it was sensitive to both Relenza and to Tamiflu. So, but again, right now we're pretty well stuck with tons of this stuff, literally tons of it. So if you ever want any,
I know who to call now. I do need it.
Could be like a good, house warming gift or something, have a couple Just a thought. Okay, I want to talk a little bit about vaccine efficacy with you folks. Vaccine efficacy last year, originally in January, came back as being about 23% effective. And that was pretty much the H3 vaccine, 45% for the entire vaccine. They since lowered that down to about 18% for the influenza A H3. But keep in mind, there's like 3 or 4 different ways to do vaccine efficacy. One is judging on who gets sick who gets influenza, period, end of conversation. The second way is to go against how many people have been vaccinated who have required medically attended influenza. That's another way. Another thing that they're looking at for vaccine efficacy has to do with CT counts. Any laboratory people in here? You know what I'm talking about if I say a CT count? No, Barbara, you do. Let me ask you what CT stands for, because I can't
It's
remember.
like the crossing point in,
Yeah.
in a PCR reaction.
Yeah.
How soon the little instrument sees the target, which would be the virus, in this case, the viral.
Right, and the higher CT, the lower the viral count, and that's what we're trying to look at to see if maybe some of these people who are mildly ill have higher CT counts, and as a result, the vaccine actually is working. There's just numerous ways of doing it. But again, when we're looking about, we were always trying to get around 60%, and what we interpret that as that you have a 60% chance of not coming down with either medically attended influenza or influenza itself, depending on what method you're using at. When it got down to 18%, again, you have to realize early in the year there was a lot of H3s that did match, but it wound up to be about 72% that did not match. I talked to some researchers who really tried to break it down a little bit, and they said if you looked at the drift strain, which at that time was the influenza A Switzerland, which is in this year's vaccine, it probably would have been less than 5%. Now, when CDC announced that, it really had some negative effects. I mean, the media got a hold of that right away. You know, influenza vaccine is not going to be effective this year. I mean, people were not getting vaccinated. Probably, they were not our friends this past year. You know, and they've helped out a lot in the past, you know, during the pandemics, but they really were not our best friends this past year. I did numerous radio and TV interviews, and I was always asked that same question: why should people get vaccinated if it doesn't work? My answer to that is, well, nobody's saying it doesn't work. We're saying it's not an optimal match, and it probably does offer some protection. All H3s, you know, unless it's a pandemic strain, have some kind of cross-reactivity. And I use the analogy that if you're in the middle of the winter and you have to go outside, you can't find your winter coat, and all you have is a spring coat, that's going to give you a little bit of protection. It's not going to be much, but it's going to be a lot better than going out without any jacket on at all. So I try to get that message across that a little bit of protection is better than no protection at all. I also try to get across these messages. You know, I've actually asked one reporter on the air, I said, what is the purpose of the influenza vaccine? She said, obviously, you know, to prevent me from getting influenza. And I said, well, you know, there's 3 ways, and I would probably put that maybe on number 3, maybe 2.5, 2A, 2B. But number 1 is to prevent complications from influenza. You know, the people get sick, but they do not require hospitalizations, especially if they're at high risk. For some of us who are on Humira for arthritis, or have HIV or cancer, whatever the case may be, you know, that's a success story. That the vaccine is working and doing its job. Now, number 2, 2A or 2B, again, one would be the fact that we don't want to get sick. But 2A or 2B, the other way you look at it, is you're protecting the people around you. The people in the nursing homes are very susceptible to this. It doesn't just naturally come in. People brought those influenza viruses into the nursing home. And that's why it's so very important for people to be vaccinated. It's also so very important to be vaccinated if you have elderly parents, grandparents, younger children or grandchildren. You know, those people don't receive the protection, and you have to do whatever you can to protect them. Did I? Still doing good? Okay.
I just had a question about the Relenza and why it's not going over real well. Is the influenza viruses less susceptible, or is it, what's the reason
Everything
behind
I've
it?
heard is the administration, the fact that it has to be inhaled. And if anybody's ever had asthma and had things like Advir, things like that, there's a technique to getting it into inhaling it so it doesn't get stuck on your tongue. My mother had that problem when she had the Advir. I mean, she got more of the powder on her tongue than into her lungs, and she finally had to go through like an old toilet paper roll, you know, to get it so she could actually breathe it in. But the administration has been the problem. They've always tried to put it into a pill or capsule, and it's just not working. So if they get that done, it'll be even better. I mean, we'd have that, we'd have the Relenza, the Tamiflu, the Paramivir, which is an IV solution. We'd have 3 really good antivirals that we could deal with at that time. So, but anyway, when you look at vaccine efficacy, anytime you read over while they're doing it, because there are many different ways, and there's many different ways on the horizon as well. I'm very curious to know about this CT count. You know, people who are very, outpatient, don't require any medical attention really, other than the fact that they feel they need to go to the doctor. Maybe there's something to this where we can prove that the vaccine is lowering it through actual scientific numbers. So that's kind of an interesting thing to think about in the future. So I just want to review again what happened over this past year and talk a little bit about what I think is going to happen this coming year. Again, 2014-15, the first sign of trouble we noticed was in March and April. And all of a sudden we started getting these influenza A viruses characterized by CDC. We sent them down as H3N2, they characterized them. And all of a sudden they were popping up as like an A Switzerland or low antibodies towards the vaccine strain. A couple of them were hitting the nail right on the head, but as we went on and on into April and even into May, we realized that there's going to be a problem. And we're hoping for the best at that point. We might have an H1 year. If you recall, a year before that, the H1 virus did not match very well, but they made some changes last year. They had much better efficacy with the H1 virus. So that was our hope, but obviously that didn't turn out to be the point. Again, over 70% of the AH3s were the drifted strain, which is in this year's vaccine. And actually was in last year's vaccine in the southern hemisphere. Over 65% or 70% are 65 years old. One thing I want to talk about a little bit in more detail is pediatric deaths. Again, I mentioned we had records of influenza hospitalizations. We had 4,716. We also had 6 pediatric deaths this past year. And that's as many as we've ever had, including the pandemic year of 2009. Now, some people say, well, these kids are susceptible, they've got a lot of underlying illnesses, and first of all, that's a hell of an attitude to take. We're talking about children dying, and that's a tragedy. I don't care if they have underlying causes or if they don't have underlying causes. So, but they have to keep the fact that these are children, the parents, you have to keep them in mind as well. I can tell you this, 5 out of the 6 children had absolutely no underlying illnesses. 1 child had a metabolic disease. The others were 5 very healthy children who died. I can tell you this, of the 6 deaths, no one was fully vaccinated. The closest one was a 6-month-old. She got her first vaccine at 6 months, 1 day. A week and a half before she was supposed to get her second shot, she developed influenza and died in a hospital. We had several children, or 3 of the 6 were foster children. Foster children going maybe from parents to parents to parents. Which is a concern of mine because, again, there's some that medical information should be shared amongst the foster parents, but it isn't always. And we want to reach out to the Department of Children and Family Services to see if we can remedy that. At least 2 of those children, I know for a fact, we're waiting for their, I believe it's a 6-month well check, correct me if I'm wrong, but the 6-month well check would have been well into January. By the time it was like several weeks and even a month after they died. They never got that vaccination. They were waiting on the 6 months vaccination, which is why our recommendation always is, once you get the vaccine available, get it as soon as possible. Yes, go ahead. Hello.
I think I talked to you about this, but our pediatric death, the coroner and medical providers were reluctant, even though there was a positive flu test, to attribute it to influenza, because their background wasn't about how fulminant or how quickly children can develop and die from it. So if the people in this room can help people learn more about that or understand, the child lived in a home where they were smokers, and I think there was some judgment about the parents took the child in 3 times in a short period of time concerned about the illness, and everybody felt terrible.
Yeah.
But it was very hard to convince them that even with a positive influenza test that the death was attributable to flu.
Right. Now the case definition is cause or associated with a cause. If it exacerbates asthma or something, that would meet our case definition. And we don't want people to shy away from them. We want to know what's going on. And I've had this issue before. I've had it with coroners in the past. Just so you know, and I'm not ragging on coroners or anything, but some coroners are ex-police officers, some have absolutely no medical background, others, we have some that are doctors. It goes the whole gamut here. But I had an argument with a gentleman up in northeastern Wisconsin about a child who died. He said, well, this 1-year-old didn't have the classic symptoms, the headache, the high fever, the body aches. I said, first of all, which 1-year-old is going to tell you they got body aches? The kid, obviously, looking at the pathologist report, had issues where she was tilting her head, you know. Obviously there's ear problems, so otitis media is a problem with influenza and a complication of influenza, especially amongst children. So I had to do a little bit of teaching on that as well. And what we've done is we have reached out to the coroners and medical examiners, and we're also reaching out to clinical pathologists in the state to really try to pull us all together to make sure we're all on the same page with this. And just in the past few weeks, we've had at least 3 children die, one from adenovirus and 2 unknown. 2 unknown that we still, I don't know if any of you follow Facebook at all, but there was an issue in Green Bay last night, you know, where they actually sent the pictures on Facebook of a 5-year-old child who was on a ventilator, I believe, in pictures. I mean, the story was good, but I never would have put a picture of my child who was on a ventilator on Facebook. My opinion, for what it's worth. But that child actually died. Had wheezing, had some kind of encephalitis, so we're obviously going to be testing for West Nile, some of the arboviruses, maybe there's some other kind of viruses going on. We need to get that family some closure on that. I don't know if you guys are even interested or have Facebook, but it really is a very compelling story, except for the pictures, which I would never have done. But again, we've had 3 or 4 deaths already, and none of them have been attributed to flu yet. I mean, there's a couple that still could be. You could do the immunohistochemistries down at CDC and find out that this could be an associative cause. So it might be coming up that it is indeed an early season. I don't know. But this whole thing about the foster children really concerns me. You know, that they're not sharing information between the families, you know, and waiting for this 6-month well checkup. We have a person in our office who has like let's see, how old is this guy? He must be about 8 months now. But we were talking, she says, yeah, he's got his wellness check in late December, and I said, Tracy, no. You can't wait that long. You know, if the vaccine comes out in late September, you need to make sure that he gets his first shot in September, and maybe you can wait as long as December, early December to get the second, but I sure, you know, based on what we saw this past year, and if it was my child, they would be, you know, 1 month apart, and I'd make the child get it, you know. You know, there's no way I'm going to be waiting on that. And she actually listened to me, so she's taken in little, whatever his name is. We changed his name, you know. I mean, it's Tracy DeSalvo, she's our Terex person, you know. I think it's Ben something, but we changed his name to Rufus Earl DeSalvo, so we call him Red. You know, a little easier for us to remember. I think his name is Ben, but he's actually getting his first shot. Does somebody say something on that? Okay, I'm just hearing things. Okay, as I mentioned earlier, we have had 1 influenza confirmed outbreak in southeastern Wisconsin so far this year. We have another outbreak of respiratory, which involves about 20-some people in a different part of the state, but it's yet to be confirmed. But again, a lot of people are getting sick. This influenza outbreak that has happened was in a dementia unit, which is good and bad. I mean, it's good in the fact that it was kind of a closed-off area, easy to confine residents and staff. They wound up with 23 people. I believe it was 17 residents, 6 staff, 2 fatalities. Influenza AH3, probably the ACE strain, but test results have not come back on that. Last thing I'd like to mention, actually there's 2 things. Clarifications for long-term care. We are going to be revising our influenza, our acute respiratory illness protocols. There was some confusion last year throughout the state. For example, certain places we were saying we are not going to, once we have somebody hospitalized in the long-term care, we send them out, we're not going to take them back unless they've been off of Tamiflu for 48 hours. I don't know where that's coming from, but that's not true. Other places are saying, no, we can't take a person back until they've been retested for influenza and test negative. That's not true. I mean, I don't know where this information is coming from, but I don't know how many times I got calls from disgruntled infection preventionists who were trying to get, don't use that term, were trying to return residents back to their nursing homes, and the nursing homes were refusing to take them. There shouldn't be any problem. I mean, after a couple of days, you know, even if they go back into isolation, if they have the proper space, which either is a private room or a room with somebody else who has influenza, or if that person's on Tamiflu, there's no reason that they can't go back to that nursing home. But we've always said is we want to stop new admissions from coming into that place for up to 7 days after the last onset of the last incidence. Not anything about the return of residents. But again, this Tamiflu thing, I just don't know where that's come from. We've had places where, and again, I'm going to say the vast majority of long-term care does a great job. But we've had places where they have actually quarantined healthy people in their rooms for 10 to 12 days. You don't need to do that either. Other places that have completely shut down activities and everything else, you can't do that either. I mean, that's getting into a resident rights issue, and I'm hoping that the memo that we put out in the next week or so clarifies this and that we can get it so that we have a little bit better cooperation. Again, it's not a majority, but again, when you're in an area where there's only 1 or 2 nursing homes and one of them is saying, no, we're not going to do it, that's pretty severe. So that long-term care memo, look for that. We'll be sending it out to local health departments. IP is going to get it. We'll put it on our website. And hopefully, for those for health department, we'll put it on our PCA portal. Hopefully you know what I'm talking about that. And hopefully it'll clarify things over this coming year. Last but certainly not least, I got a few more minutes. I just wanted to bring up what might be happening over the next month up here. You guys remember back in April, May, we had quite an instance of the avian influenza, H5N2. We had 10 outbreaks in Wisconsin, 9 in commercial flocks, 1 in a backyard flock. The vast majority were in the Barron, Chippewa area. There also were a bunch in Jefferson County. One is Genio, the other one is Tyson, I can't remember. But we had somewhere around almost 2 million birds that had to be destroyed or who died from influenza. The theory is that it likely will come back in late fall, sometime in October. So we've been preparing for that, looking for, trying to update our surveillance systems. One issue that really did not work the first time around was this. We had been preparing with our Department of Agriculture for an outbreak of influenza, high pathogenic avian influenza 1. These things happen in bunches. Look at Minnesota, they were doing up to 20 at a time. You know, we were doing up to 4 or 5 at a time. We thought that was pretty bad, and it was, but you know, we prepare for one, and they have the staff to do it, to come in and depopulate and do the disinfection, but then they have to bring in other people from different states and sometimes private contractors. We need to get more information from those people so we can monitor them the 10 days after their last exposure. Because they're dealing with a very, very high amount of virus when they're doing this disinfection, even though they're supposedly wearing PPE. That's another issue. Apparently there was times in Iowa where they were telling people they didn't have to wear PPE, and it's like, no, I don't know where that's coming from either. So there's a lot of mistakes made, a lot of good things happen, but we really need to monitor those people much better. We're also making sure that if these people get sick, I think we tested like 9 or 10 people who came down with symptoms. I think one guy actually had the flu. Remember, this is still in late season flu. And you know, to make sure that that person contacts the clinic, we contact the clinic, make sure that they're using their PPE, which means the N95s, doing the nasopharyngeal swab, sending them directly down to state laboratory hygiene. Don't send them off to your own places, please, because we want them down to state labs as quickly as we possibly can. So again, something's worked really well. We do need to do a much better system of monitoring people. And a lot of these places, contractors are coming from different states. So, you know, I talked to people from Florida, North Carolina, and it's like, did you know that we had people in Wisconsin? It's like, no, I didn't. So I should have known. But that's one of the areas where we're really going to try to improve is our monitoring of the depopulators. We have taken responsibility of doing the workers. And most of the workers do not have any insurance. So we have got memos put out to them as to what to do in case you get sick. We put them in Hmong, we put them in Spanish, trying to get the information to them as quickly as possible. That just don't sit on these things. If you're not feeling well, we'll work with you. You know, we'll figure out a way for payment if insurance is an issue. We put them on Tamiflu. We took out of our cash again at the state to help these people. And what we did is we put them on twice a day, 75 milligrams twice a day for 10 days, which is double what you normally would see. And that's based on recommendations from CDC. Again, we're dealing with a very high amount of virus in these areas that obviously they kill the birds very, very quickly. You know, so we want to be sure that they're protected as quickly as possible. And sometimes they run into problems with scripts. Maybe a pharmacist Lady Emily.
I'm not a pharmacist.
Oh, pharmacist, friend of pharmacist Lady Emily. You know, where we're recommending this 10 days, you know, of treatment twice a day, 75 milligrams. It's like, no, CDC says this. Well, actually, not for a case like this. We've had exposures in laboratories, and this has been our protocol all the time, is to double that dosage, double the treatment dosage, from twice a day, 5 days, to twice a day, 10 days. And again, there's times where it gets into money factors. we don't want money to, or delays to, be a factor on this, and that's why we've been offering her to get into our cash as quick as we possibly can. So, probably will come back. Hopefully not to the extent it has before. She's coming. She's coming.
I was just wondering if you were also treating the people that just lived on those farms, because in some cases, they're family owned, or the family is working the farm.
Yes, those are the workers and the people who are living on the farms are our responsibility. So we've kind of given the responsibility to the Department of Agriculture to be the lead for the depopulators and the disinfectors and all those other people, but we need to know that too, because they're not following them once they go back to their homes, and that's where there was a breakdown this past year. Hello.
Hi, Tom. I would like your opinion on what to recommend to travelers, especially with the population that I deal with students studying abroad. If they need a flu shot amongst all the other vaccines, what's
Yeah,
important
I would
about
definitely
that?
recommend flu shots, and again, it's you can't always tell what's going on throughout the country or throughout the world. For example, in New Zealand and in Australia, they are just done with their influenza season. It was predominantly a B. You go over to South America, they have H3s. There's been H1, H3s in Central America. But I would say any vaccine that's available, it's going to give them at least some protection, and I would make a strong recommendation that they get it.
Thank you.
Any other questions? I think it's about 7 after. We've got a few minutes here. Want to ask Allison anything about Ebola? No. Oh, we're just yanking you if you call that, you know. You're going to be here.
You were talking about earlier that I know with H1N1 we knew that it would affect different age groups right from the start.
Right.
But are you saying that that's true of different types of flu? And at what point do we know that when that's developed? Or?
Well, as a general rule, H3 has always been the more severe of the pathogenic flu-wise. H3s have always historically hit the elderly population more than the younger adults. It hits everybody, but this past year is a perfect example when you had 70% that were hit by the H3, whereas the previous year, you look at the statistics, those in the high numbers were in the 30, 40, 50-year-olds, and that was the H1 year. We also had more hospitalizations amongst children at that particular point. So influenza Bs also were ones that historically tend to hit the younger and elderly people more than anybody else. And again, things can change. The influenza is going to do what influenza want to do, but what do we need to do to follow that? That's my job in looking at hospitalizations, and that's where we're looking at the weekly reports. And I'm kind of considering if maybe I shouldn't do the weekly reports, and have this by region too, so you know exactly how many hospitalizations are going on in your region and the state. I think that might be interesting, it might be a help. Anybody have any thoughts on that? I just got to get an artiste to do that for me. I'll figure it out a way to do it. But that's one of the things I want to add. I want to add information about the differences in the two influenza B strains, especially for those people who've been vaccinated. And again, I think most nursing homes are probably going to use the trivalent, but it'd be nice if they went with the quadrivalent as well. So some changes in the way we're going to look at things, but look for your weekly reports. That's where you're going to find that information. Any other questions or comments about anything? I don't really care. I'm here for you.
Do you recommend the quadrivalent over the...
She's running her little, yeah.
Do you recommend the quadrivalent over the trivalent super senior?
That's a hard question to answer. I asked that of John Tempe, who is the head of the ACIP. There's no formal recommendation that the high-dose Fluzone hasn't been around long enough to be evaluated, although I think in the next year or two it will. Preliminary reports is that you get a better reaction to it, a better antibody response. But again, it's only a trivalent vaccine. We get caught with one of the Victoria strain, which is not in the not in the trivalent, but is in the quadrivalent. I mean, that can be just as devastating. So it's kind of a horse apiece right now. I personally, for my purposes, I want the quadrivalent. I'm not old enough for the Fluzone, but I want to make sure that I'm covered by is by all 4 viruses as much as possible. And you'd be surprised that a lot of people still don't know the difference. You call away clinics and like, oh yeah, we have flu vaccines. Like, do you have the quadrivalent? It's like, oh, well, we have influenza vaccine. It's like, do you have the quadrivalent? You know, and the quadri who? And it's like, no, for God's sake. You know, so I made an appointment 2 years ago, went in, I said, I want the quadrivalent vaccine. They don't have the quadrivalent vaccine. You know, so this year I'm kind of pulling a few strings, going right to my doctor, you know, and not going through the other people. Yeah. Any other, and anybody come over here and make all that a little more? Kind of fun, actually. Other questions, comments, anything about virus season? Remember, we have influenza starts first, followed closely within peak activity virus speed, probably within about 6 weeks after, followed very closely by human metapneumovirus. And this year, human metapneumovirus is cyclical. Last year was pretty low. This year, we're expecting it to be a lot higher. And that's end of March, early April. And that's something that, again, there's no vaccine for it. It hits the elderly population and the children very hard. We've had numerous fatalities in long-term care facilities over the past few years, including, and some of you might know this, but my parents died of human metapneumovirus in a nursing home back in 2009 as well. So it's kind of a near and dear virus to me, no bad one, but it's something that's always kind of in the back of my mind. But again, our reports that we put out, we're going to tell you when the season starts and when things are starting to increase. So hopefully the information on the report gives you what you want. And if there's something that we're missing, you got to tell me about it. Because it looks good to me, but another one. Now somebody over here is thinking about a question.
I just to do the nursing home again. You're saying, like my sister works at one out in Seattle, and it went rampant. They just shut down the place and made everybody stay in their room.
Yeah.
So you're saying, no, you shouldn't do that.
Not really, no. I mean, to keep people, we're not quarantining anybody. You quarantine the well and you isolate the ill. Now, if it's something where they had 60, 70, 80% attack rate, maybe that's a different story. Maybe then there is a reference. But when we're talking certain wings and maybe an attack rate of 10 to 15%, the other people do not have to suffer with that. I mean, the problem with that is they run into like a dementia if they are confined to their room. I've seen that happen. I used to be a nursing home inspector, and I've seen that happen in the past where they would confine people to their room. Honest, good story. One guy actually got hepatitis B, and they were so paranoid that they weren't doing things right. They confined this gentleman to his room, and he just went ballistic. And it was also in a tiny little nursing home, no air conditioning, and it was 90 degrees. So, yeah, to me that was abuse, but you know, it's very sad to see.
Okay, thanks.
Okay. Back to the side. I'm being mean to you, aren't I?
Okay.
I'm
I need
not.
the steps today. Sorry.
Okay. Oh, part of your Fitbit or whatever?
There you go.
There you go. Good. Anything else before we close it up for the day? Go back to our normal jobs? Okay, well, thanks you for your time. I appreciate it.